screens there. We've got some questions already been sent in. You should be able to see on that panel down there some of the questions that are coming in. Please try and keep them as specific to coronavirus as possible, rather than perhaps general cholesterol-related questions, which we can try and address, but this is a particular special webinar specifically for coronavirus and COVID-19 crisis that we are currently in. So Dermot, as those questions start to come in, can I ask you some of those that have already been emailed through to us, people concerned that there might be any extra measures people with high cholesterol need to make around high cholesterol? Is there any additional worries that people need to have if they have high cholesterol?
Broadly speaking, people with high cholesterol should take the precautions that have been recommended for all people, regardless of their medical condition. The reason we're interested in high cholesterol as a charity is that we know that people who have high cholesterol untreated over a period of years will be at greater risk of heart disease and other vascular conditions. Treatment of the high cholesterol to bring it under better control will reduce the risk of heart disease and these cardiovascular conditions. But in terms of the risk related to COVID-19, the coronavirus infection, what we're concerned about is to be able to identify those people who would be at particular increased risk of severe complications of the coronavirus infection, such as severe pneumonia. And that's really to do with people who've got cardiovascular disease. Obviously, if you have high cholesterol untreated, then you may be at greater risk of having cardiovascular disease, whether you've got symptoms of cardiovascular disease or not. On the other hand, those people who've had a high cholesterol and been treated for it will probably be have a better cardiovascular health than people who've never had that cholesterol treated. So the answer to the high cholesterol question is that having a high cholesterol doesn't increase your likelihood of getting a COVID-19 infection, nor does it increase your risk of severe disease. However, if you have cardiovascular disease, you would be considered in a higher risk group. One of the things that's been said about people with familial high cholesterol, for instance, is that they may have had a high cholesterol lifelong and not known about that. And that's one of the reasons we're keen to get those people on treatment as early as possible. But for the majority of people, high cholesterol levels are something that shows up in middle age and tested for in NHS health checks, etc. And identified early and treated appropriately, the risk of heart disease in those people will be much reduced. So I would reassure anybody who's got a high cholesterol, unless it's due to an inherited cause that hasn't been treated, that they're not going to be at any increased risk from this infection.
So people with FH, if it's treated either with a statin or PCSK9 or other measures, oughtn't to be overly concerned other than the general population?
No, absolutely not. I think if you've got familial hypercholesterolemia, you're at no greater risk than somebody without the condition if you've been properly treated. If you've never had your familial hypercholesterolemia investigated or diagnosed or treated, then it depends a little bit on your age. Younger patients, particularly those who are in the under 30s or under 40s, are unlikely to have any cardiovascular problems, even if they have familial hypercholesterolemia and it hasn't been treated. But patients who are at older age groups who didn't receive treatment as a younger person, they are people who, I think, like other people with cardiovascular disease, should be considering themselves to take the best possible precautions against getting the infection. But I must emphasize that having familial hypercholesterolemia doesn't increase your likelihood of getting infected. The the big thing with this coronavirus is that people who have underlying health conditions that give them feel like a less robust cardiovascular system, or less robust heart and circulation, could be at increased risk of a more severe complication. And therefore, we're only really concerned if people have had untreated familial hypercholesterolemia, for many years, and therefore could potentially have underlying heart disease that they're not aware of.
People are also asking about LPA. So should somebody that has unidentified LPA equally be concerned and unconcerned?
Yeah, well, this is a kind of Donald Rumsfeld question, the known knowns and the unknown unknowns. But what I would firstly about having high LPA, high LPA we know means that you've got larger numbers of stickier cholesterol particles, which could deposit on the arteries and cause furring up of those arteries. We also believe that treating high cholesterol in people who have high LPA reduces their risk dramatically. So what I would say is that if you've got high LPA, with or without the diagnosis of familial hypercholesterolemia, at the same time, the most important thing is that you continue to take your cholesterol-lowering treatment, and that that will provide the best possible protection for the cardiovascular system. And if the cardiovascular system is well protected through continuing medications such as statins, PCSK9 inhibitors, other medications such as blood pressure medications, diabetes medications if you're diabetic, those are the best safeguards for the cardiovascular system. Should the cardiovascular system be stressed by a COVID infection? So that's really the issue here. We know that if you're unfortunate enough to get this infection, and if you're unfortunate enough to get a pneumonia, which is the severe respiratory complication of that, then that's poses a challenge to the cardiovascular system. So the better cardiovascular health you have, the better. And if you are in poor cardiovascular health, then you need to make the best possible arrangements to avoid getting the infection at a time when the health service is otherwise stretched. So that's really the principle of the advice here.
So how about medication? A little bit more about those, perhaps. A number of questions are coming through around, should I still be taking statins?
Yeah. Absolutely. I think as I mentioned to you, the principle here is that we want to keep everybody as healthy as possible as far as their cardiovascular system's concerned. And that means keeping cholesterol well controlled so that their arteries are as healthy as possible. And if you've got healthy arteries, you're more likely to withstand the stress of an illness. It's actually been shown in many studies over the past couple of decades that any severe illness, whether it's sepsis or pneumonias or surgical trauma, such as undergoing an operation, if you happen to be in a statin at the time you underwent the illness, you're more likely to get a good outcome and go through that with fewer complications. So we'd advise everybody who's been prescribed a statin that they should continue to take the statin. Don't interrupt it. There's no rational basis for doing that. If people are admitted to hospital with an virus infection, then the medical staff in the hospital will advise appropriately as to what medications are continued and what ones aren't. I think in terms of our cholesterol-lowering medications, I expect that all of those would be continued. I think one of the issues that arises is, for instance, with injectable medications such as PCSK9 inhibitors, and whether supplies might be interrupted. But I'm not aware of any such problem at the moment. But there's no suggestion that any of these medications for controlling cholesterol have any effect, if you like, on a bad way, or on the outcome of the virus infection. In terms of other medications, the one that's been, a couple of ones have been talked about. The simplest medication, the one that you buy over the counter that has been talked about a lot, is ibuprofen as an anti-inflammatory, which can be used an alternative to paracetamol for treating fever. And we know that for the majority of young healthy people, it doesn't matter which one of these you take if you get a fever. But we do know that people with cardiovascular disease or with kidney disease and high blood pressure and a few other conditions are actually, have always been told to avoid these, what they call NSAIDs, or non-steroidal anti-inflammatory drugs, of which ibuprofen is one. The reason for that is that ibuprofen reduces inflammation, but it also alters the production of some of the little chemicals from the blood vessel lining that regulate the flow of blood to the kidneys, for instance, and that there's a belief that perhaps in the context of severe illness that it may affect your kidney function or something like that. So we would say that older people or those with cardiovascular disease or kidney problems or diabetes, better to stick to paracetamol just in case. There's been really very little hard information about the use of paracetamol versus ibuprofen in these COVID or coronavirus infections. It's all pretty much theoretical, but at the moment you would say that you'd feel safer with paracetamol. The other type of medication that's been mentioned in particular is blood pressure medication. This is really a little bit of a sort of surprising concern, really. But it has been found that this particular virus seems to attach to the cells and the lining of the airways via something called ACE2. And we recognize that a lot of people are on treatment with drugs called ACE inhibitors. And that's really related to ACE1. So ACE2 and ACE1 are little enzyme sort of components in cells in our bodies. And it's been suggested that perhaps an ACE inhibitor might affect the chances of your getting the virus infection or the severity. Once again, there's very little information. Early on in the first outbreak in China, it was observed that quite a lot of people who had severe infection had also had high blood pressure. But what people don't know is anything about what treatment those people were on. So at the moment, the advice from European Society of Hypertension, they've looked at all the evidence, is that people should continue to take their blood pressure medications as prescribed, and that pending further kind of expert advice, if doctors and hospitals are treating people with high blood pressure, they may decide to change their blood pressure medication depending on the condition of the patient at the particular moment in time. But it has been theoretically.
Just the message there, just to reinforce that, is that if you are on a medication, if you have prescribed a medication such as a statin, such as a blood pressure tablets, whether they're ACE inhibitors or any other lower blood pressure, take them as prescribed by your GP, because it's the heart disease that puts you at risk.
Yeah, I think there's a question on the Q&A there is, why does hypertension increase the risk? Well, it doesn't seem to increase the risk in a way that we can currently, if you like, we can't make decisions, about the drug therapies that could be, for instance, protective as far as blood pressure medications are harmful. That information just doesn't exist at the moment. it's an interesting observation that among the people with severe pneumonia, there seem to be more people with high blood pressure. And one suggestion, as I say, has been that maybe the virus can attach to these ACE2, but we don't really know whether blood pressure medication helps or hinders that. It's just not known. So at the moment, we believe it's a bit like if people continue to take blood pressure medications, they will have a healthier cardiovascular system and will be more able to respond should they fall ill, no matter what they fall ill from. But we do know that people who stop their blood pressure medications are going to be at increased risk of heart problems and stroke, which are far more common than severe illness through the COVID infection. So it's an interesting academic point about this hypertension connection. But as I say, at the moment, the advice I'd strongly give is keep taking your medication for your blood pressure and don't try to change that, without, and we get further information about that.
So that interesting question here about the increased risk of getting diabetes on statins, which is often raised. Diabetes, of course, being one of the at-risk groups. Can you say a little bit about that kind of association that is often raised by people who have been prescribed a statin and what's often reported very often in newspapers without substance about that risk of diabetes?
Yeah, well, as you mentioned, diabetes is a health condition that is identified as putting people at greater risk of a more severe severe illness with coronavirus infection. But that is likely to relate to people who have established diabetes over a longer period of time. That also affects their kidney function and other things. The relationship with diabetes and statins is a curious one in the sense that not all statins seem to have the same effect. I was involved in a study in west of Scotland where they showed that pravastatin, for instance, seemed to reduce your risk of diabetes. And then among the studies that have been done with diabetes in the years, with diabetes incidence in the years since then, it's been shown that there's a variable effect. But the likelihood of developing diabetes while on a statin is greatly influenced by the likelihood of developing diabetes overall. So that the people that seem to be at risk of developing diabetes while on a statin are those people, for instance, who have other conditions that increase the chances of developing diabetes. People talk about metabolic syndrome. That's a condition where you've got an accumulation of weight in the upper part of the body, around the abdomen, around the neck, etc. And that condition itself is one where you seem to need more insulin to keep your blood sugar steady than other people who are slim, for instance. So there does seem to be a greater production of insulin in these people. And we know that statins can not only slow down cholesterol production, but they slow down insulin production somewhat. So it could be that these people are developing diabetes because they can't keep up with the amount of insulin they need. We recognize that whenever people are treated with statins, normally we intervene to reduce all their other risk factors, including controlling weight and increasing exercise. And for the most part, if those things are done, it will greatly offset the risk of developing diabetes. But the small increase in blood sugar that can occur and maybe move you across the line for the diagnosis of diabetes is a very small extra risk for cardiovascular disease compared to the benefit of getting the cholesterol well controlled with the statin. So there's a trade-off in some people, but for overall, most people are much better off having their cholesterol controlled at the expense of a slight rise in the blood sugar, which of course can be controlled in other ways.
Can we talk a little bit perhaps about diet and lifestyle as well, and how to control cholesterol in these times when people perhaps have gone out shopping, they've done a big shop, we've seen lots of queues outside supermarkets, but also the challenge that there is around what's available in the shops at the moment. and folk have been out shopping with, and packing up with canned food, maybe pre-prepared food, and also the limitations that we might have upon the ability to go to parks and exercise. Things that people should be looking out for on the labels on packs that might be more dangerous, should I say, if that's the right word, under these circumstances. If you have got high cholesterol, what should you be avoiding? What sort of food should you not eat?
Well, like the people tuning in, I think we're all rediscovering how to cook here. Those recipe books that have been gathering dust on the shelf all those years are now coming in handy. And we're also finding that we are probably eating more in terms of fresh vegetables and incorporating those into our dishes with pastas and so on. Everybody seems to be stocking up on pasta, and maybe it will not do us that much harm if we're maybe eating a little bit less meat and other sort of foods that we normally would eat a bit more of. I think the fact that everybody is cooking at home is probably going to be beneficial rather than relying all the time on takeaways, because that's kind of dropped off a cliff. So it could be that in all of this, we may find that people are eating more healthy and actually losing weight despite the strictures that this has put on them. I think it is important just to stick to healthy eating guidelines, but with so much more time available to most people to prepare meals. I think Jay Rayner was on the radio the other day saying he'd spent 6 hours preparing the evening meal, and I think with that extra time available, you're able to read up all the labels and check and see what's the healthiest thing. But we always advocate a Mediterranean style diet, and I think that those principles would still apply.
And what does that mean, Dermot? What generally?
Well, eat fresh fruit and vegetables, a variety of foods. I think most of the vegetable shops are not in short supply. The things that people are stocking up with are not the things that we were probably going to be sort of. I mean, obviously the cans of baked beans. I think people are maybe putting those in their garage in case there's a complete lockdown. But I think if we're making more of opportunities to cook from fresh, use plenty of fresh fruit and vegetables, lean meats, fish, chicken, that type of thing, whole grain pastas. I've been in the supermarket and find that all the pasta's gone except the wholemeal stuff's still there. We'll use that. The brown rice is always there, despite every other sort of rice having gone. So I think there are ways to do that. I'm not a professional dietitian, but I think I know we can eat healthy even with these restrictions.
I think we've got plans to hold some more of these sorts of webinars specifically on healthier eating. Yeah. So if people are buying canned food, they should be looking for the salt, the sugar content, as well as the saturated fats.
Yeah.
There's a question come in around homozygous FH, a rarer condition within FH and a very high level of cholesterol for people. We know that not only GP surgeries are restricting access, but lipid clinics across the country are now closing down as staff are deployed elsewhere and the clinics are used. Is there anything specifically for homozygous in general terms, I think, about the availability of medication and treatment such as apheresis that is going to be a challenge?
Well, I think that we're just going to have to, go by the specialist units themselves, which are distributed around the country, some in areas where there is a lot of coronavirus admissions at the moment, and staff are being redeployed, and maybe the number of medical nursing staff are reduced. For homozygous FH, most patients are on specialist forms of treatment, and many of them actually have to come in for fortnightly apheresis sessions where they have to be hooked up to a machine to draw the blood and clean it, if you like, of the LDL and put it back in. I know that in Newcastle here, in our own unit, we're basically just watching the situation, because at the moment there isn't any shortage of staff, but they may be redeployed at any moment. And certainly people will be concerned if they're unable to access, if you like, their regular apheresis treatment. But as with all forms of inherited high cholesterol, familial hypercholesterolemia treatment, heterozygous or homozygous, is a marathon, not a sprint. This is about keeping the cholesterol under good control over many years to maintain and improve the condition of the blood vessel linings. So even short-term interruption, we don't expect this crisis is going to last a very long time. It's not going to, we hope that within a few months things will be getting back to normal. And I don't believe that for a short term anybody will be seriously disadvantaged. And I know that our apheresis unit wouldn't want a long-term interruption. For the majority of people, the mainstay of treatment is medication, which can easily be supplied from pharmacies on an ongoing basis and isn't going to be interrupted because of the crisis.
And a couple of similar emails that have been sent in from people in a similar situation, in that they've been they've gone to the GP, they've had a cholesterol test through about 6.8, bordering this at kind of 7. Both have got family histories that raise concerns around early heart attacks and strokes in the family. The individual, otherwise fit and healthy, keeping an active and fit life, but the GP hasn't suggested any statin or any other course of medication. But they're both concerned that this has interrupted any follow-up that they might have, either in terms of a blood test or a GP. Is there anything that they could do in the meantime?
Well, I think anybody who's had a high cholesterol identified, what we'd normally, the next steps would be to look and see if there are any other medical conditions that might be contributing to the high cholesterol, such as, for instance, an underactive thyroid, diabetes, or any other condition. I would expect that the GP will have done those tests in the first assessment, and the decisions about treatment normally come later on, once all those other potential conditions have been excluded. When cholesterol is extremely high and there's a very obvious, if you like, likelihood of a diagnosis of, for instance, familial hypercholesterolemia, and we're really talking about patients whose cholesterol is above 9, often GPs will, having collected initial blood test for assessment, will then just get people started on a statin at a moderate dose, such as 20 milligrams of atorvastatin. And that's pretty effective in the majority of people, of getting cholesterol 80% of the way it needs to go to get properly controlled. If people have got more moderate cholesterol values, they may be being assessed using the risk assessment tools such as Q-Risk to look at their 10-year cardiovascular risk. And normally that would be done before a final decision is taken on treatment.
Is that something similar to the heart age tool that patients?
Yeah, the heart age tool tells you a similar, uses the same inputs, the same risk factor inputs, and will usually give you a similar answer in terms of risk discrimination. So people who are at higher risk of a cardiovascular event over the next 10 years would be prescribed statin treatment in the same way as people who had a previous heart attack, etc., were prescribed statin treatment. But if people have never had a history of previous cardiovascular events, often they might be advised to make some lifestyle changes, diet, exercise, get the weight under control if it's too high on the BMI, and then reassess the situation before starting treatment. Because clearly, if you start treatment at the same time as you make radical changes to your lifestyle, you're never going to know whether it was the diet and lifestyle changes or the medication that's actually brought things back. So unless there is urgency about the matter, then these lifestyle changes actually kind of a long-lasting benefit which can be beyond the cholesterol changes that can happen. So they're not a trivial intervention, they're very important. And as I say, they can contribute as much as the medication to improving the outlook in future.
So maybe because the worry that these emails are highlighting suggests that, even though you've got a high cholesterol perhaps at the moment, but other sides seem to suggest that you may well, in the normal circumstances, want to have a speedier access to your GP, but there are still things that patients themselves can do to reduce that cholesterol in the meantime, but immediately there's nothing over concern to be to raise. But and I've just plugged our website, down here. There's lots of tips and handy ways to reduce your cholesterol and manage it with diets and recipes and what to eat during this crisis and beyond.
Yeah, but I would say, however, that if you're somebody who who's had a heart attack or a stroke or cardiovascular condition is just developed, then normally statin treatment is part and parcel of the management. May have been started in hospital, but again, we wouldn't normally say that people should wait until they've made diet and lifestyle changes if they've already had a cardiovascular event, because in that situation you need both the belt and the braces to keep things right.
And so people with families with FH, and FH clearly been inherited and possibly passed on to children. Is there anything in addition that the families with children with FH need to think about during this time? And is there any kind of guidelines that we want to talk about? Heart UK have developed its own particular guidelines for children, and we've certainly got a big push on getting young children screened for high cholesterol, so we can identify more patients with people with FH under the National Screening Committee. But is there anything that children with FH need to consider during this time?
No, I would say that at this time we wouldn't be concerned about children with FH any more than any other children, really. The fact that they've got high cholesterol means that they will need treatment to prevent them developing, cardiovascular disease, in future, and particularly in adulthood. But we know, and we're grateful, I suppose, for the one blessing of this coronavirus thing is that severe disease doesn't seem to be common at all in children. People with children with familial hypercholesterolemia wouldn't be any different from normal children without FH in respect of that. So no, I wouldn't be concerned about them at all. The only possible exception to that might be children with homozygous familial hypercholesterolemia, who are a very it's an uncommon situation to be in. But like the homozygous adults who've got two, if you like, bad cholesterol genes, they may have underlying cardiovascular conditions, and their teams that look after them will no doubt give them the advice they need. But the advice would be that they should adhere very closely to the social distancing and avoid any possible contact with anybody who might have a symptoms suggestive of the infection. But for the vast majority of our patients with familial hypercholesterolemia, particularly children, I think we can be confident that they're at no greater risk than unaffected people in the household.
Thank you. So we're coming up to the end shortly, so do keep those questions coming in.
I saw a question here. Somebody had asked about home cholesterol tests.
Oh, yeah.
Came up, and what we'd suggest about home cholesterol tests. Home cholesterol tests are a bit of a mixed bag. I think that in order to make decisions about treatment, you really need a cholesterol test, done through your GP, which is done by a sort of an NHS laboratory, which will give you a full profile, a breakdown of the good and bad cholesterol, the triglyceride fraction, and will allow treatment decisions to be made. And also, treatment decisions are usually based not only, as mentioned, on the cholesterol profile, but the full risk profile, and will normally require measurement of other condition things, like, for instance, the thyroid function, the liver function, blood glucose, or HbA1c at the same time before decisions are made. In terms of monitoring for people who know they've got a high cholesterol, I'd say that if you just keep taking your tablets, I don't think you need to be worried about fluctuations in cholesterol. I think we can just put that, if you like, on hold. The only situation I think that could be potentially concerning for people is if they recently had their treatment changed and they were wondering whether the treatment change had actually been successful in improving the cholesterol level. But what I would suggest is that we would just make the change and stick with the change until basically the heat is off and we get a chance for a routine cholesterol test to be made. I'm concerned that somebody might, get a home cholesterol test and they get a result that they didn't expect, and then they're going to phone their GP. Their GP is very busy with coronavirus, and I think it could just create more problems than it will solve. So I think I wouldn't go there.
Could it also be the case that somebody does a home cholesterol test and it gives them an okay?
Yeah, well, we know that
And actually that full blood test might suggest otherwise.
I think we're concerned that the quality of the test might not be quite the same as the test you would have done with a blood test through the laboratory. So, yeah. I think we just...
Thank you very much. So, there's one email that's come in that I think I might be able to answer. Is there a group for people with FH? Well, yes, it's Heart UK. So keep signed up and keep in touch. Let me just have another quick look to see if I think you've got a helper behind you there, Dermot.
Yeah, there was another question about the only value of the statin is the anti-inflammatory effect, correct? Well, no, that's not true. We know that by lowering bad cholesterol fractions in the blood, that it actually reduces the burden of lipid on the scavenger cells in the blood vessel lining, the macrophages, and that does reduce inflammatory activity. But a statin is not like ibuprofen. It's not an anti-inflammatory medication. It's one that reduces the amount of cholesterol in the tissue.
And is it true somebody's claiming that there's all sorts of fanciful ideas around in the press and by certain individuals about high cholesterol and the benefits of having high cholesterol, as well as those that create scare stories among statins. The latest one apparently is whether high cholesterol actually protects somebody from fighting from the virus. Surely that can't be true.
What I would say about that is that a lot of the studies that are quoted on this are observational studies, which can't account for differences, which may be related to underlying disease. For instance, we know that if you become ill with a wide variety of problems, there can be what they call acute phase changes that will reduce cholesterol in the blood temporarily during the illness. And this is to do with the switch in protein production in the liver and switch to fighting the illness itself rather than building new tissue. So there are those changes, and observational studies sometimes have used these and without really taking account of that underlying physiology.
Great, thank you very much. Well, we're at the end, unless there are some super urgent questions that haven't come through yet, which we can take. Can I encourage you, there's a little poll down the bottom there, just give us an idea of how this was. I know it was a bit clunky, so forgive us again for it being the first attempt, but under the circumstances of pulling it together, I think we've done a pretty good job. Yeah. Thank you very much to you for your time. You're extremely busy.
No trouble.
Well, part of the NHS, as well as all the work that you do for Heart UK. There's a poll down the bottom there. Just give us an idea of a couple of things. Thank you if you could just click on that and give us an answer to those questions that you have. But don't forget, on the Heart UK website, we'll try and keep those pages. Well, we will keep those pages up to date as far as we possibly can. But keep subscribed to the newsletter that you will receive from us very frequently, I think, over the next few weeks while we're in this this challenging time, with some more similar sorts of webinars as this. But do, keep in touch and let us know if there are any issues, generally speaking, that we could have some topics upon, as well as, your own experiences and stories. Now we're all kind of at home doing our new office. This is my new office, for the next few weeks. Dermot's got a beautiful lampshade there as part of his office for the next few weeks. Okay, many thanks indeed for everybody for dialing in or tuning in, and we'll be in touch. Cheers. Bye.
Bye.